Dear colleagues, I'd like to introduce our next talk, Professor Buhl from the University of Mainz. He's a prominent speaker in the field of asthma of COPD today. He will speak to us about asthma update. Professor Buhl, it's always a pleasure to hear you with us.
Thank you, Ashraf. And again, hello, dear colleagues. My topic and the last topic before lunch break is an asthma update. And I also have some potential conflicts of interest that I will, of course, share with you now. My first topic, and I will only very briefly touch upon it, but it's a question that is asked to all of us very, very frequently. What about vaccination? And as a member of the GINA committee, I would like to communicate our main message. Please recommend COVID-19 vaccines to your patients with asthma if available. There have been some reports in the newspapers and in the media, of course, about severe allergic reaction. This is not against the vaccine, but against some ingredients such as polyethylene glycol and others. And all these side effects, if at all, they happen at a very low rate. So far, there have been 21 confirmed cases among the first 1.9 million doses, and almost all of these side effects occurred within the first 15 minutes or so. So feel perfectly safe if you keep the patient under your surveillance for half an hour or so. And then, in my opinion, the message is very clear. Recommend the COVID vaccine to your patients with asthma. The first topic was already introduced by Ian Paward in his talk. He wonderfully underlined the scientific rationale behind the change in recommendation on how to treat patients with mild asthma. We now know, and you have seen the scientific rationale behind it, patients even with mild asthma are at risk of serious adverse events. And we also know that the need for higher SABA use is a clear parameter, a clear indicator that something bad is likely gonna happen. And I will show you just briefly a European study done in Sweden to prove this point. More than 350,000 asthma patients with at least 2 or more collections of a drug against obstructive lung disease in a quite long period have been monitored. And 30% of them collected 3 or more SABA canisters per year. And as you see on the two graphs, no matter if you look at overall mortality or if you look at asthma-related mortality, there is a very clear signal. The more SABA your patients use, the more rapid-acting relievers alone your patients use, the higher the risk of a serious event, in this case, mortality. So SABA use, increased SABA use is a clear indicator something is about to go wrong. This is why GINA now for a little bit more than a year clearly recommends, if at all possible, your reliever medication, the reliever medications you prescribe, they should not only contain a rapid-acting bronchodilator, but also an inhaled corticosteroid. And I won't quote the cardiologist, but again, this is a population-level risk reduction strategy which will avoid serious side effects, even mortality. So the story is very simple. Instead of prescribing a SABA, please prescribe a fixed dose combination of an inhaled corticosteroid with a rapid-acting bronchodilator. In most countries, the only available such fixed dose combination are fixed dose combinations of an inhaled steroid with the rapid-acting bronchodilator formoterol. And you just tell the patient, use this combination exactly the way you use your reliever, as shown on this graph. If you have symptoms, you take as many of these drugs as you need. And if you have no symptoms, you just don't take any drugs. Does this concept work? Yes, it does. Because compared with SABA only, you also have always the right dose. It's an autopilot. You always have the right dose of an inhaled steroid on board. If you need more reliever, you get more ICS. This means you do not only relax smooth muscles, but you also prevent airway inflammation, and the importance has Ian beautifully shown. This leads to a reduction in severe exacerbations, which this is the left-hand graph, which is similar to what you achieve with a regular dose of a steroid. However, overall, your total daily ICS load, the amount of inhaled steroids your patients need, is much lower with such a concept. So in my opinion, this is a classic win-win situation. Patients get what they want, immediate relief. They are prevented from exacerbations, and at the same time, they get what they also want, as few inhaled steroids as possible. And this has been nicely shown in two very large controlled clinical trials, the Sigma trials, more than 6,700 patients. The only criticism of these studies was, yes, doctor, this is a controlled study. So what do you expect? Patients take what they need. My patients don't take a steroid on a regular basis. In a real life, this situation, this will be different. And the answer is, unfortunately, no. The same concept has been tested in a novel START study, and this is an open label trial. So patients and doctors knew what the patient was taken. And again, comparison of only a SABA with an ICS formoterol, both as needed, and a regular inhaled corticosteroid plus a SABA as needed. And the outcome, left-hand side, is very similar to the controlled studies. Frequency of exacerbations is as low with ICS formoterol as it is with maintenance budesonide, and of course much higher in the SABA only arm. And a remarkable finding of the novel START study, if you look at severe exacerbations, so events which bring patients into hospitals or intensive care units, here the frequency, this is the blue bar in the budesonide formoterol arm, was even lower, because when patients have severe symptoms, they take more reliever, so they get more steroid, preventing severe events from happening. This is why SABINA now clearly, and many other guidelines have adopted this concept as well. This is why we now clearly recommend use an ICS formoterol combination as needed in patients with intermittent and mild asthma. And this very nice analysis of Paul O'Byrne shows you, in my opinion, the only advantage of SABA only is you prevent patients from taking a steroid. This is this very thin blue bar at the bottom. All the other parameters you want your asthma patients to benefit from: better lung function, reduced need for systemic steroids, reduced exacerbation, reduced inflammation, less symptoms. In all other aspects, the new concept, ICS formoterol on demand, is superior, as nicely shown on this graph. And by the way, if you need to intensify treatment because patients have more severe disease, or because there is whatever reason you want to intensify treatment, you can maintain the concept. You can maintain ICS formoterol on demand as shown here, and you just switch to a concept where you also give the drug on a regular basis, so either morning or evening, or morning and evening, and you tell the patient, take it now on a regular basis, plus maybe more inhalations as needed. This gives you the opportunity to switch from more intense treatment to less intense treatment without even having to change the medication. And this is now part of the GINA guidelines as shown here. In steps 1 and 2, ICS formoterol only as needed is the preferred option. In higher intensity treatment, step 3 to 5, treatment with ICS formoterol as needed on demand is a recommended option on top of regular treatment with ICS LABA, as long as the LABA is formoterol. So now you have the real flexibility to choose whichever treatment you consider it's best for your patient. Ian has already introduced triple for asthma. This is now no longer only available for COPD, but now also for patients with asthma. And of course, we recommend the triple combination already for quite some time. Until very recently, only the LAMA tiotropium was approved in patients with asthma, which is why tiotropium is here specifically mentioned in steps 4 and 5. We now have fixed dose combinations. In my part of the world, the mometasone indicadrol and glycopyrronium is approved, and very recently also the beclometasone formoterol and glycopyrronium triple combination has been approved. And You have seen the Captain study. The third fixed dose combination is about to be improved very soon. So again, we now have triple combinations, free and fixed, in patients with severe disease. This is just to briefly make the point. You understand the graph because you have listened to Ian Pavord's talk. Of course, the addition of an LAMA on top of ICS LABA, this is the blue bars on the left-hand side, will improve lung function. You are not surprised, I know. This is a self-fulfilling prophecy. 2 bronchodilators are better than 1 bronchodilator. More interesting is the right-hand side. This is the frequency of exacerbations. And as Ian told you, in patients with exacerbations who have a low dose of a steroid, the increase in the steroid dose is superior to the addition of a LAMA when it comes to preventing exacerbations. This is why on the right-hand side, when you already have a higher dose of the steroid and add in a LAMA, there is not much of an added benefit. So this clearly tells us in patients with more severe disease, what Ian showed you, treatable traits, is an important component of management of our patients. And this is irrespective. It's completely your choice. It's the benefit for the patient and you decide. This is completely true for patients with fixed dose combinations or for patients with free combination. This is the ARGON trial. It's a comparison of a fixed dose combination, mometasone, indacaterol, and glycopyrronium with, and this drug you know for ages, with fluticasone, salmeterol plus tiotropium. And as you see here, there is not much of a difference between the blue and the yellow bars. Both triple combinations, free or fixed, work perfectly well in your patients. It's your choice. You choose what you think is best for your patient. And in my opinion, this is very important because on top, if you want to make the life for your patients as easy as possible, you give them just one inhaler with all the components, and they additionally need a SABA for on-demand treatment. However, if, for instance, they are on maintenance and reliever therapy or single inhaler, no matter how you call it, if they are on such a strategy, you can just add a single LAMA, so far only tiotropium approved. So again, your choice, you choose what you think is best for your patient. This is my conclusion for patients with moderate to severe asthma, triple treatment. This is perfectly well working in free and fixed combinations. If your preference is lung function, the addition of the LAMA works perfectly well. If patients have also exacerbations, make sure they have the higher ICS dose on board. And I can only mention it, you know why. Blood eosinophils and FeNO are wonderful biomarkers to predict the effect of an inhaled steroid. If, however, your patient is already needing higher doses of systemic corticosteroids, or if the patient has extrapulmonary manifestation of the asthma, and I'll show this in a moment, then of course, on top of triple treatment, you also need another type of drug. This is biologics, and now we are discussing severe asthma. Here, I can only recommend our severe asthma booklet. This is the severe asthma guidance from Gina. Feel free to download it for free. And as Ian pointed out, here you have the classic treatable traits approach. If your patient has a clear-cut allergic asthma, allergy is the leading symptom, clear correlation between exposure to an allergen and asthma symptoms, then of course it's an anti-IgE approach. Omalizumab is, if eosinophils are the dominant parameter, then it's an eosinophilic asthma, then clearly anti-IL-5 receptor or anti-IL-4 13 receptor antibodies are, in my opinion, the preferable choice. And you see on this graph, and I won't have to go into details, you see all the parameters which will help you choose the right drug for the right patient. Even so, and it happens to me all the time, even so, in some patients, your initial choice may be wrong. And in such a situation, in my opinion, patients deserve a second choice and a second chance. This is one study from Ken Chapman in Canada. He looked at patients who, because there was no alternative, were treated for severe asthma with anti-IgE, with Omalizumab. However, obviously, a small subpopulation in reality had eosinophilic disease. So these were, once available, switched to mepolizumab. As you see on the right-hand side, this led to an immediate reduction in the frequency of exacerbations. So clear indication, if drug A doesn't work, consider a second trial with drug B. This is now also true for patients beyond severe asthma. We know there are many comorbidities related to severe asthma, and here are just a few examples. Among them, and this is very frequent, at least 2 out of 3 patients with severe asthma also have chronic rhinosinusitis with nasal polyposis. And we now know for these patients, also our biologics initially developed for severe asthma, they work as well. And on this list here, you also see atopic dermatitis, dupilumab, anti-IL-4/13, wonderful drug for atopic dermatitis. And we also know that anti-IgE is a very good treatment for severe cases of spontaneous urticaria. This is just to prove this point. Recently approved by at least the EMA and the FDA, Omalizumab not only works for severe allergic asthma, it's also a very potent drug, such as dupilumab, for patients with nasal polyposis. This indicates that we now have very nice treatment options beyond just severe asthma. We can now effectively treat these comorbidities. And this is a story which will go on. As Ian said, this decade is our decade. This is a study, a phase 3 study, showing that other drugs directed at eosinophilic asthma, such as benralizumab, the anti-IL-5 receptor, also have a very high potency in patients with nasal polyposis. This is the anti-trial showing that no matter which parameter you look at, anti-IL-5 treatments are also highly effective against nasal polyposis, and it is safe to predict that very soon we will have an approval for this type of drug in this indication as well. Now I, in my opinion, told you everything I think is relevant to know for an asthma update. With biologics, always consider all the parameters that your patients complain about to define a responder. I showed you not every biologic works in every patient. If in doubt, stop or switch. Always, in my opinion, a patient deserves a second chance. We now also know that unfortunately in most patients, these biologics are not disease modifying, they're just excellent drugs. So in most patients, we need to continue treatment, and it's important to also maintain at least the basic inhaled treatment, even in super responders. This is what, in my opinion, is relevant for you in type of asthma, and I can only repeat what I just told you. We live in interesting times, and we are now able to deliver the right drugs based on proper diagnosis to the right lungs, and we no longer have to treat more and more lungs with more and more drugs. Thank you very much for your attention.
Thank you very much, Professor. That was very informative. So I'll try and summarize the main messages like you put them on the last slide. Professor Buhl has suggested that when it comes to the COVID-19 vaccine and asthma, studies have shown that out of 1.9 doses of 1.9 million doses of vaccines, there were only 21 anaphylaxis cases, and that would encourage us that we should give a positive feedback to our asthmatics to take the vaccine, which we've been doing locally. We get a lot of questions from asthmatics asking and actually deferred from vaccine vendors because they say you have chronic disease, you should not have asthma, and they actually have to have a letter from a specialist saying that their asthma is controlled, they're okay to take the vaccine. I also would like to mention the point that Professor Buhl went over, and that is the fact that over 365,000 asthmatics, 30% of them who were taking more than 3 canisters of SABA were at higher risk of hospitalization and at higher risk of mortality. That's why the GINA guideline as of May 2019 have changed and now strongly advising patients that no SABA should be taken away. Whenever SABA is taken or a short-acting bronchodilator is taken, an inhaled corticosteroid should be taken with it. This is for the mild asthmatics. When it comes to the severe asthmatics, remember now, triple therapy is a new thing that's available and approved in many countries for patients with severe asthma, where ALABA, ALAMA, and inhaled corticosteroids are in one device, and this improves the outcome when it comes to the compliance, makes patients' symptoms better, exacerbation better, lung function definitely better. And last message, but not least, remember, we have more options in the 2020 and 2021 than we had 3-4 years ago. If in the past, we only had one biologic, now we have more than 4 or 5 biologics available in most of our markets. If your patient does not respond to one biologic, it does not by all means mean that this patient will not benefit from a different biologic. Keep working them up, assessing them, and try another treatment until you get your asthmatics under better control. My question for you, Professor Buhl, for mild asthmatics who are so much attached to their SABA, salbutamol, and they're not willing to take combination therapy to at least ease your mind as a physician, he's not going to take bronchodilator without an ICS protection. Would you still recommend to them taking an inhaled corticosteroids, even if they're taking 5 puffs of the SABA a day? You'll tell them take 5 puffs of ICS in that day?
This is actually an excellent question, and my answer is very clear. If patients need 5 inhalation of SABA per day, they are clearly, first of all, undertreated, and second, they are not intermittent or mild asthma. In these patients, I would rather recommend a chronic treatment, 1 inhalation in the morning or evening, ICS, LABA, your choice, and then you can use either SABA on top of it, or you can, if ICS formoterol, there are many combinations. If ICS formoterol is your choice, then you can tell them take additional inhalations of this combination also as needed. So if patients need more than 1 or 2 SABA inhalers per day, it's no longer mild asthma, it's now moderate asthma, and they need a higher intensity treatment. Very, very good point, a very important point.
Thank you very much. And we see those patients a lot. And suppose somebody is mild asthma, truly mild asthma, and they're taking only once a week SABA, and they come in with an exacerbation, actually severe exacerbation requiring intubation. I have a question from the audience. Would you still consider him after that exacerbation, after he is extubated and back to home? Is he going to be still your mild asthma, or you actually have to step up with them after his mild asthma has led somehow to a severe exacerbation that might not be necessarily related to his disease? Maybe he had a trigger, maybe he had a bad exposure.
I mean, this, as you said, this is depending on the trigger. If this is a very unique experience, it never happened in many years before, then it may you may still consider this patient a mild asthmatic. However, if this patient has exacerbations all the time, and if every upper respiratory tract infection triggers an asthma exacerbation, I would not consider it mild, even if they are poorly symptomatic in between the events. Then I would rather recommend a chronic treatment with on a daily basis. But I mean, let's face it, half of all patients with asthma have mild disease. And for these patients, you can switch off your brain. Give them ICS formoterol, you're doing everything wrong, and they do automatically what they need. They take more inhaled steroids if they need it, and if they have no symptoms, they don't take anything. It's as easy as can be.
Thank you. And I think that's important. So you wouldn't consider that the mild asthma, if he gets severe exacerbation requiring intubation, is not in your mind that mild asthma anymore. You have to think twice now about where to categorize him. And last question, Professor, biologics and vaccine. Somebody who's severe asthma. The guidelines locally and internationally are not very clear. I am on biologics. How many weeks after the biologic dose, and I'm stable, controlled on my biologic for severe asthma, how many days, how many weeks after my dose should I take the COVID vaccine? They say 3 weeks. What about the second dose? What do you advise those asthmatics?
Ashraf, thank you very much. Very, very, very relevant question. Answer is very clear. Forget about the biologic. There is absolutely no risk of interference between biologic and the vaccine. We have in clinical trials looking at influenza vaccination, at pneumococcal vaccinations in patients treated with biologics, directed, for instance, against interleukin-5. And there is absolutely no interference. The vaccine response was as good in patients treated with a biologic as it was in normal individuals. So please, if your patient is on a biologic, still give him a chance to be vaccinated against COVID. No danger here.
And no time restriction, how many weeks after the dose?
Absolutely no reason to consider. However, keep him under your surveillance for half an hour to make sure if you are one of the 21 in 2 million, then it's good to have you at your side and, give him some autopen and a little bit of steroid, and then this story is over.
Sure. And I agree with you, the anaphylaxis rate among our colleagues, at least listening, Professor Bassam Mahboub from Dubai has told me he came across 2 cases so far in his clinic. So they are there, but they're very few. Professor Buhl, thank you very much for this session, and I wish you a very enjoyable Friday evening. Please send my regards to your family and stay safe.
Thanks to you. Stay safe, and please enjoy the lunch break now.
Thank you very much. My dear colleagues, I'd like to ask you to join us again after 30 minutes. I'm sure a lot of you can't wait to start also the next session on COVID vaccination. We have Professor Ward from Canada joining us after 30 minutes, 2:00 p.m. UAE time sharp. Inshallah, we will start the session. Thank you very much and see you then. Bye-bye.